So today, what we're doing is we're demonstrating the lateral approach to SI joint fixation, and the concerns with the lateral approach for most people generally is anatomy and structures and things where they may hit the anatomy they don't want. So what I typically do in this approach, when we're demonstrating is we try to make sure we stay inside the safe zone. So what I'm going to do, I'm going to start off, which is the way I always start off, is I draw a little, sort of like I call a little safe triangle. And as long as I stay inside of that safe triangle, with anything that I'm putting in, with any guide wire I'm putting in or anything like that, it usually goes pretty good. So first what I want to do is take a picture of that. And what I'm really trying to do, take another picture. I'm trying to take another picture. I'm really trying to get really the most cranial position, picture that. The most cranial position where I really want to go. So probably somewhere right at about, picture right there. Well, actually, no, picture right there. And this really, one more. There we go. So right in there, another picture. Well, one more. One more. Okay, so I'm going to draw a line kind of right there on the cadaver. All right. Now I'm going to from here, I'm going to get really the most dorsal aspect. Take a picture there. Picture. And what this is also doing, picture, is this is helping me get the orientation of the sacrum, picture, of when, and I can look at it really kind of on the cadaver, and I can kind of see how the sacrum is really orientated, and on the patient. Picture there. Again. Picture there. All right. So that takes really just a couple of extra seconds. So I'm going to make an incision right there. So we'll probably have to, Tyler will have to do that out of the way. But so take a picture here. And this really kind of helps me. I can just basically put a little mark on where I want to make my first incision. Picture that. And then get a general idea where to make my first incision. So we're going to make it right there. All right. So that's going to be my incision. Thanks, right now. So come all the way in with the floral to give me more room. And so I've made my incision. Now the next thing I do once I do this, and I make this incision here, is I want to, somewhat do some blunt dissection. Thanks. Blunt dissection of the fat that getting down to the muscle. And the way I do that is I just do that in a 90-degree fashion with either a long coker or something like that, like just to kind of even the fat out, just to kind of get me down a little bit. And then that gets me started to the depth of where I really want to go. To make it even easier, let me have this jamshidi. So I'll use a jamshidi really to kind of get me oriented really onto the sacrum. Picture? And really all I'm trying to do, picture that, is get my jamshidi, picture that, in position, picture. Hold on just a second. Picture that. Picture. Picture that. Picture. There we go. Picture. Okay. One more. I want to come a little bit further back. Picture. All right, there we go. Picture. Now once I get it in place up against the sacrum, picture. Then I can start it, picture. Right there, picture. Now where this really helps you with using the jamshidi, picture, is that if you're on the other side of the bed and everything's kind of backwards, then it kind of gives you, a better, you can kind of anchor it onto the sacrum things, yeah. Picture. 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 The enemy of good here, picture. Trying to make it perfect. Picture. Picture. Hold on just a second. Picture. Again. Again. One more. Okay, I like that. So let me just take the mallet. And what I'm going to do is I'm just going to kind of get it started. Picture that. Picture. We're sliding off here. Picture. That's the problem. Hold on a second. Picture. Really. Picture. Again. Again. There we go. So I'm just going to kind of get it started here. Picture. 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 Again. Picture. Picture. Okay. So as it, picture that. One more. There we go. Okay, so picture that. Make sure it's still going that direction. Picture. Okay, once I really get it started, what I will do is then I want to go into AP, or really kind of an oblique AP, and just check that view. And when I come back to this view, I'm going to talk a little bit about really where you don't want to broach, and really the areas where you don't want. So take that quick picture where you really don't want to go, which I didn't really discuss yet, but I'll mention. Quick picture, and then go back lateral for me. Good. So we're headed straight towards the SI joint, and I like that trajectory. Now, where I don't want to go is I want to make sure that my trajectory with the initial Jamshidi, go ahead and take a picture real quick. I want to make sure it doesn't go below sort of that ventral line of the sacrum. And as long as I know, as long as I know it's headed in a direction that I like, I'm just going to kind of pull it, picture that.
Recording in progress.
Picture that. As long as I know it's headed in a direction that I like, that it's not going to approach that, then I can mostly go back into oblique and on just the joint, kind of an AP oblique, and really do most of the rest of the procedure in that view. So picture that. Good. So what I'm going to do is I'm just going to go ahead and send this across, picture. And that joint is pretty well fused. Picture that. Oh, can you oblique about 15 your way? Yeah, your way. Towards you, yeah. So let's open the joint up a little bit. So take that picture. There we go. All right, so we're right there. We're definitely across the joint. Now, at this point, really, most of the work is done. So now I'm just going to come in with a guide wire, and I'm going to get a guide wire started. All right, take that picture. All right, so I like that. So now I'm going to back my Jamshidi out. Picture that. And I'm just making sure that my guide wire is staying really where it is. Picture that. Just, and just check it multiple times just to make sure it's, in a pretty good position and it's not moving. Picture. Great. So now these systems, most of the lateral systems, when you see them, they have a dilator system. They have the initial dilator and then the second dilator. And really the purpose of that is really to kind of do blunt dissection through the muscle and just work your way through the muscle. And the way I do it is I sort of corkscrew or I spin it as it's coming down, okay? And as long as, so take a picture of that. And then at that point, typically, picture, and I always like to kind of keep my guide wire about right there. But generally what I'm trying to do is making sure I'm always staying on bone and staying on os. I know as long as I stay on bone and I stay on os, then I feel like it's, most of the safety or most of the safe zones in that situation are usually in a pretty good position. So now what I'll do is I'll take the initial dilator out, picture that. And again, what I'm mostly doing here with taking multiple pictures is just making sure my guide wire is staying in position. So I'll take a measurement, and in this particular instance, based on where the guide wire is, I would say it's a 50, so we're going to grab our 50 screw. In this particular situation, let me have that third one right there. Now, I think as long as you stay on bone and on os, then you're generally going to always be safe. So what I will typically do is I'll have someone come in and hold the third dilator in to keep me up next to bone. Picture that. Okay, one more. All right, great. So now I have my screw. And we can take this screw, you can load the screw with some DBM with it, but basically we're gonna take the screw down, and at this point we're just gonna drill the screw in position. Now this particular screw, picture that. This particular screw, again picture, is a self-tapping screw. So picture. So you'll really see it and feel it. Picture again. You'll feel it get purchased right away and just go across, picture. What's also specific about this particular screw, picture, is it has a conus ending, which means it has a stop, picture. So it's gonna get to a point, picture, where it's not gonna go anymore. And that's really where it will really compress the joint together, picture. And I'm starting to get to that point. Picture. And I'm there. Now, as long as I leave the guide wire in, picture that, which it is, picture, just making sure. From here, and I could show you, I'll take this dilator out, and now if we want to put in a second screw, which I typically do, so go back lateral for me, I use the guide wire as my initial anchor. Yeah, I come all the way, I'll bend it up for you a little bit. So take that picture. And there's our lateral projection of the screw. So I'm gonna use, sort of the initial guide from here at this point to come in and decide where I wanna put my second screw. Picture. And get the picture. All right. So I'm gonna take a guide wire here. And most of the systems, picture that. Most of the systems, let me have a little mallet right here. Most of the systems have a typical guide like this. But then what we can do is you kind of can mallet this in and kind of get it started. And then you can get your second screw started the same way. And I'm just gonna go ahead and pull this out and show this to you and set it. And so take a picture of that. And so that's where the second screw would be. So it basically, when we go across and we place the second screw the same way, then usually they're perfectly lined up and they work well. So I'm going to avoid putting the second screw in here so we save the cadaver, but I can open it up to any questions.
So, Brian, I'll kick off with the first question. So you demonstrated the lateral approach, and I think a good demonstration mid-portion of S1 to the mid-portion of S2. So some people will consider this a more difficult approach than some of the other approaches, for example, the posterior approach. Can you make a comment on, number one, safe zones for the lateral approach, and number two, the level of difficulty for posterior approach?
Yeah, so the safe zones, and I'll use the Jamshidi as an example. If you take another picture, as long as you stay above where I have the Jamshidi at right now, you're in the safe zone. So the gluteal artery that runs, or any type of really bad vasculature that runs, usually runs ventral to this line here. And so that's one of the other reasons why I like to draw the grid out, or sort of the safe triangle out, because then what it does is it just kind of gives you a line of where not to go. That's the first part. The second part is as long as when you're deploying the screw or putting the screw in, as long as you're staying up against os with the dilators, then you'll be up against bones, so no screw or anything like that is going to clip or broach any gluteus muscle or anything of that nature, moving in. I like this particular approach from a standpoint of the compressive nature of the lateral approach. I think the posterior approach has some utility for for some physicians, but in a situation where you can't always get into the SI joint, this is a great option if you have that problem happen to you. I primarily use this approach, and and I didn't really demonstrate it here. I've really kind of focused mainly on one screw really closer to the S1, but a second screw would go a little bit further than that, the S2. If you had somebody who is like a high velocity type patient, you could put in a third screw. And I just think it just gives much better long-term results.
Brian, this is Neil. If I could, I'd like to review for everybody the triangle that you were outlining. So the anterior sacrum is the most recent Jamshidi x-ray you took, and the vascular structures are below it. The upper line that you drew was the posterior border of the sacrum, and the neurologic structures are above that. And the most proximal rostral line that you drew was the upper reach of the sacral ala, and the L5 nerve is coming right over the top of that. So essentially what you're doing is you're outlining where two neurologic anatomical danger areas are and one vascular danger area, and you stayed within that triangle, and those are the borders and the structures at risk that are outside that triangle, correct?
That's correct. And what, it helps you for that standpoint, Neil, as well, but what it also helps you if you're on the other side of the bed and you flip the room and everything is kind of backwards. As when you're trying to stay in the correct position, sometimes you can get a little confused. And as long as you draw those lines, in my view, and stay inside of that triangle, you're always inside an area of safety. And I think it makes the procedure quite easier that way when you do it that way as well.
So let's open it up to questions, comments. Let's check and see if we have anything in the chat box.
Thanks. Yes, Doug, there are a couple of questions in the chat box.
The first question is, are you using inlet outlet views to align your screws and identify S1 for our third screw?
So you can, and what we really should do to show that, and I didn't demonstrate that, is to get me an inlet view real quick. And if you look at the current fluoro image that we have up, where I drew that ventral line, you can go ahead and go do that. Is where I drew that ventral line. That is, like I said, that's my most ventral aspect of where I go. And what you'll see in an inlet view, so if you can give me a good inlet view, is you can see the screw never comes, let's actually do it. You'll see the screw never really gets close to that ventral border. So take a quick shot of that and show that. Let's see if we can show that for demonstration purpose. You'll need to, yeah, there you go. So slide towards you. So I think that's really helpful. And as you can see, we never ever really get close to broaching through the sacrum as long as we keep that ventral line in view. As long as we know we never go through that.
Okay. Another question was 2 or 3 screws for the sacroiliac joint.
So this is a great question, and this is a question that comes up a lot. So typically on a standard average, velocity type patient, and what I mean by that is someone that's probably, 70 to 80 to 85 years old, maybe is not really overactive. I think 2 screws are great. I think that's generally all you typically need. If you have somebody who's a little bit more robust, more active, somewhere between 40 and on up into that range, where a posterior approach after somewhere about a year would probably start breaking down and start failing, that's a really good patient option to put in that third screw. You can combine a posterior and a lateral approach for that particular patient, but if you're trying to think more long-term for someone who's a lot more active, that's where I would start thinking about a third screw. So it's highly patient selective in that situation.
And remind the audience again the name of the manufacturer and system that's demonstrated here.
This particular system is Versa. It's called an SI conus system with the with what I was demonstrating with the screw has a conus ending. The approach itself is pretty standard, I think, for almost across most all manufacturers. This is just the one that I primarily use.
And another question was, is there a particular name for the safe triangle of the lateral SI fusion approach?
No, I just made it up. I just came up with it. I don't know where. I just call it that.
We kind of traditionally refer to these as bone corridors. So the bone corridor of S1, bone corridor of S2, although we've highlighted the areas around that are no-go zones. If you take an approach from one hip and you go through the bone corridor of S1 and S2, you can come out of the other hip all the way to the skin and not injure anything of any importance at all. So these are wide safe zones that you can go through. Good biomechanical reference paper that if you want to look forward to the answer, and Dr. Rich covered this already, how many points of fixation do you need? It's a paper for recent meta-analysis of 55 papers from JOUKAR, Joukar. And it says, to distill it down into one sentence, 2 points for sure, maybe 3 is what it says of fixation, just as what Dr. Rich previously described. So with that, I think we'll transition over to the next segment.